Good morning, Krishni. I can confirm that we are now live.
Thank you, Tom, and good morning, everybody, and welcome to our meeting in public of the NHS Herefordshire and Worcestershire Integrated Care Board. Good to see everybody this morning. A few things really just to start the meeting off. As a reminder, this is obviously being recorded and we will be placing it on our website as well as streaming it live, and we welcome anybody who's observing the board today. Also worth mentioning that it is actually our last meeting as a, if I can call it, as a standalone board of Herefordshire and Worcestershire, because by the time we convene in January, we will be a revised board with our cluster partner, if I can describe it in that way, with Coventry and Warwickshire. So this is our last standalone board, and I want to say a few things about just sort of a few welcomes and thank yous really. In light of the changes, just wanted to particularly mark that this is Sarah Raystrick's last board with Herefordshire and Worcestershire. Sarah, we just want to thank you at our public meeting for your massive contribution since we established the board. You've been a fantastic non-executive member for the board and deputy chair, and contributed hugely on particularly on our health and equalities agenda and public engagement. So we particularly wanted to recognise that today. I knew you were still with us for a few more weeks, but it was an important moment to mark it at our public board, so thank you very much. I also want to take a moment to say in public how much we miss our colleague Mark Yates. We obviously have not got his presence and contribution here today, and this is the first public board since he passed away, and we had a memorial for him, and of course his family held a funeral as well. But just wanted to remember Mark and to say really how much we valued his contribution to the board and the support he provided to all of us as colleagues, and the difference he made to the community that we all serve. And so it's important to take that moment to remember Mark. I think Beej is with us, although I can't see him. There you are, Beej.
I am, thank you, Krishni. Yeah, no, the camera is playing up, so my apologies, I was video off.
No, that's fine. Beej, welcome, because you are obviously acting chair at the Health and Care Trust, and we welcome you warmly to this meeting, and look forward to your ongoing contribution. So thank you. I think we have a few apologies. We have received apologies from Ellen Rule, partner member and CEO of the Health and Care Trust, and also Katie Hartwright, Chief People Officer for the ICB, and I believe Simon Adams as well, CEO of Health Watch Worcestershire. I think that's all the apologies for today. So on that basis, I will continue with the rest of the meeting. So we're on item 3, which is declarations of interest and choracy. So I believe we're chorate at the moment. And I just want to check, are there any declarations of interest for the public meeting as opposed to the confidential meeting? Any that we particularly want to note in light of agenda items today? No. Okay, thank you. We obviously have as part of our governance log, we do have declarations of interest noted for all members and participants of the board, so they are available for the public to review. Hannah, just on the governance log, which is item 4, is there anything that you want to highlight? I think there was one action which has now been completed, if I'm right.
Nothing else to highlight, Krishni.
Thank you very much. Just to confirm, Hannah, obviously, given that we are going forward into a clustered board arrangement from January, I assume we'll need to review the board forward plan to sort of bring our two plans together. So the members might just want to note there might be some changes that we need to make to that, and presumably we'll look at that together in January. So just for noting, really. Okay, minutes of the previous meeting held on 17th of September are there for our approval. Is everyone content to approve them at this stage? Yep, great, thank you. We'll take those as approved. So we're moving on to the substantial items on the agenda, which start with our section on patient and public voice. I'm not aware that we've got any questions from members of the public. We do encourage members of the public to submit any questions if they wish on matters pertinent to the business of the board. So please do take that opportunity. In the absence of those, we'll move on to the patient story and I'll hand over to Kath, please.
Thank you, Chair. Thank you, Chair, and good morning. In urgent and emergency care, we are facing some of the most significant and sustained pressures our system has ever known. Demand continues to rise, delays in handover remain a real challenge, and too often patients wait longer than any of us would want. Today, I want to share Elizabeth's story, which shows what becomes possible when we do things and look at things differently. By redesigning pathways, bringing specialist expertise earlier into the journey, and focusing on what truly improves outcomes, we can transform not just flow and efficiency, but lives. This is a story about working smarter across organisational boundaries and the profound difference that can make for our patients. Details have been anonymised to maintain confidentiality of the patient and family. Elizabeth is a 52-year-old woman who lives with her husband and teenage children. She leads a full and busy life and had no significant medical history. One afternoon, while out shopping with a family member, Elizabeth suddenly began to feel unwell. She became dizzy, felt sick, and developed a severe headache. Within minutes, her condition worsened. She lost feeling down one side of her body, her vision became blurred, and she struggled to form words. Her family member recognised that something was seriously wrong and asked for help. Bystanders supported them and an ambulance was called. The crew arrived promptly and assessed Elizabeth quickly, suspecting a stroke. We know that rapid access to specialist access to treatment is vital. It gives patients the best chance of a good recovery and reduces long-term disability. On that day, the paramedics supporting Elizabeth were able to utilise the new pre-hospital stroke pathway, designed to speed up diagnosis and treatment, which launched on the 1st of October this year. The ambulance crew carried out a video triage call with a hospital stroke specialist while still with Elizabeth at the scene. This brought expert input into her care at the earliest possible moment and made a clear and significant difference. During the call, the specialist assessed her symptoms in real time and agreed a clear management plan with the crew. As a result, Elizabeth was taken straight to the CT scanning department on arrival at the hospital, avoiding the emergency department entirely. A brain scan confirmed she was having a stroke and she received appropriate treatment without delay before being transferred directly to the acute stroke ward for monitoring and early rehabilitation. By the next morning, Elizabeth had made an excellent initial recovery. Her symptoms had resolved and she was well enough to be discharged home with support from the community early supported discharge team, who continue to help her with rehabilitation at home. Elizabeth described her care as positive, efficient and reassuring. We recognise that ongoing challenges remain across our system, particularly the time it takes for ambulances to hand patients over to emergency department staff. Previously, patients with suspected stroke would travel to the ED before being seen by a stroke clinician. The new pathway allows specialist involvement straight away and, when appropriate, enables patients to bypass the emergency department entirely. It shows how working differently can improve patient flow, support ambulance services, and most importantly, improve patient outcomes. Elizabeth's experience demonstrates how rapid access to the right specialist team at the right time can make a life-changing difference. And it also reminds us of the critical public health messages underpinning this work, recognising the signs of stroke, calling 999 immediately, and ensuring our population understands that rapid access to specialist care is essential. By strengthening public awareness and redesigning pathways so expert input is available sooner, we can improve outcomes not only for individuals like Elizabeth, but for our whole population. Thank you, Chair.
Thank you, Kath. Can I take a moment to invite any questions or comments on the patient story? Anyone would like to comment? Stephen, please.
Yeah, I think stroke is one of those pathways that would be really good to keep having a look at, because I think we've done so much good work, not just at the front end that the patient story describes, but I think also the other elements of it. I think we've had a bit of a success really as an ICB is around the work that we've done with community as well, and how it's joined up, particularly in Worcestershire. So I think if you look at the whole pathway, that's a real improvement. I think the bit that we're focusing on now is how do we take that learning and apply it to the rest of the UEC pathway. Sometimes it's not as easy because people present with multiple problems or whatever, but I think there's a real case here for learning from excellence, rather than often we learn when we get it wrong, don't we? This is one where this is absolutely an improvement. So I think through our UEC group, it's how we take that learning and put that into the other pathways, but partners play a massive part in that. So particularly like our Health and Care Trust colleagues and the early community discharge team, I think this is one that's working across the board really well.
Great, thank you, Stephen. I totally support your comment about learning from things that go well, because you're absolutely right. It can, you know, yes, of course we need to learn from things that go wrong, but sometimes when something works well, it's how transferable it is, and this is a great example of that. Vicky, please.
Thank you. Very similar to Stephen's point. I was just interested in when this improvement was put in place, because to have a great story like that takes a lot of work to make sure that actually all of that's in place. Everybody's aware of the support that they can access. So just wondering, Stephen or Mary, just how long that initiative has been in place to result in a patient story that's so positive.
I can happily come in there, but so this has been planned most of this year. It's actually with WMAS and Region and our ICB stroke programme board. We started on the 1st of October. Within the first month, we've had some really positive patient stories and real enthusiasm from the clinicians who see it both in WMAS and in the acute, seeing it working really well. And the bypassing of the ED, where that's appropriate, it can't happen for every patient, but where that's appropriate has been very positive.
I mean, that's amazing, Christian, if I can come back, because that's just in such a short period of time. That is amazing. So it goes back to Stephen's point about you know, appreciating the excellence and building from that.
Yeah, thank you, Vicky. Sarah?
So it was a quick question about the service, and is this a service that's in hours, or is this have we got this sort of scaled up to an out of hours 24/7 service? And my other point was just picking up on what Stephen said really about the community services, but then even further along from that, not to, you know, we shouldn't underestimate the psychological impact. You said that this lady was, you know, fit and active, looking after her teenage children, busy life. Actually, to be told that you've had a stroke, it can actually be really life-changing, even if the symptoms resolve. And so making sure that we've got that psychological support available for people to access should they choose to, hugely important. And this lady didn't need, it sounds like she made a really good recovery, but for some people, Ben, it's access to those even wider community services, isn't it? The advice services and the benefits and all the different things that people might need if their lives are sort of catastrophically changed. And so it was just that the length and the breadth of this pathway, as well as this really great story from the acute part.
Thanks, Sarah. Mary, are you able to comment on both of those?
Yeah, I believe it's up till 8 p.m. at night. Remember, most of our strokes do attend ED early morning in the morning, and that's the pattern that we have. On the life after stroke, so it's interesting. It's often not the very affected strokes that need that support. It's people like this individual that need that early support. We have got a very good life after stroke service, particularly in Worcestershire. We need to strengthen it in Herefordshire through the Stroke Association. They do an absolutely fantastic job in supporting these individuals and corralling all the professionals to give them that advice. Psychological support is a challenge because of the workforce that we have, and we recognise that. And in the business case that will be coming forward at some point about the whole stroke service and, you know, making it ready for the next 10 years, you will see all of the aspects of the stroke pathway in that business case.
Great, thank you, Mary. Thank you. Just one final point from me. There was a particular reference to video triage call as part of that particular story, and I was interested to know, is that in use for, sort of to Stephen's point from the beginning, really, is that something we do for other types of you know, instances where people need support urgently or need specialist, almost a sort of diversionary approach in terms of, or access to very rapid care? Mary, is that something you can comment on?
Yeah. This is a fairly new, it's very simple though, I have to say. It's video triage. It's not a massive IT issue. WMAS are keen, as Stephen says, to look at other areas to roll this out where it's appropriate. It is a little easier for stroke because it's quite distinct symptoms, so that's something that's being discussed regionally. We are, though, you know, rapid AI, the rapid artificial intelligence between the stroke centres at Worcester Acute and Wye Valley is working exceptionally well as well. So they are the sort of forerunners for using this sort of technology.
Stephen?
Yeah, just how we are looking at it. I was talking to our hospital or home team yesterday in Worcester that we're setting up. So there's a trial of kit that they're about to launch, which is it monitors a lot. It gives a whole range of ability to monitor stats and other things. And then the really interesting bit, I think, for us that we'll come back with as well, is the kit actually contains like an iPad. So if anything, if the patient starts deteriorating, they can literally do a call straight away with the patient or with their relative carer wherever they are. So I think we've got a success story in stroke, and once you've got one success story, it's easy to transmit that through clinicians, isn't it, to say it actually works here, it's not so scary now. So I think we might see it rapidly start to expand out because it's a really efficient way of doing it as well.
Yeah, I mean, it's a great example of use of technology and something that's not too challenging, as you said, Mary. I mean, it's not, the technology itself doesn't sound a particularly difficult to use or implement, so that's really positive, and ultimately, you know, it's a really good example of improving both the patient's experience but outcomes, most importantly, which is what we really want to influence. So thank you very much, Kath, for sharing the story. I think it does give us great insight, and obviously we'll pick up that theme as part of our spotlight on urgent and emergency care, which will follow shortly. So we move on then to the next item on our agenda, which is our CEO's report. So Simon, over to you for some highlights, please.
Thanks, Krishni, and good morning, everybody. So hopefully people have had a chance to read the report. Thanks once again to colleagues for their help and support in developing the content. Just to draw out a few things, as we normally do, so I'd probably right and proper that we start with the latest update on our transition as an organisation, our team's transition. So a few points of quite significance really over the period since the last board meeting. So firstly, we are approaching the end of the consultation period with those people involved in executive and director roles across the two ICBs. So we're proposing a new structure that's currently out for consultation. It's been a really constructive exercise. I think there are probably some tweaks that we will make as part of the consultation reflections. Just so the board are briefed, because I know we've discussed this at some of the development time, there are 36 people involved in the consultation, and we're proposing a structure that has 19 posts. So broadly in line with that 50% reduction that we've been asked to do. Secondly, and this isn't covered in the report, but finally at the end of last week, we were given approval and funding to launch a voluntary redundancy scheme. It's a national voluntary redundancy scheme that is applicable to all ICBs and to NHS England. So that was launched as of Monday. Lots of support now going into the staff groups to help and support people really to make their own decisions around what they might want to do. Clearly, once we've done the executive and director changes, we'll be looking to move down the tiers of leadership in the organisation. I do still think that probably is a process that will take us a further 6 to 12 months, really dependent on a number of factors. But one of the variables is just how many people come forward for voluntary redundancy. So that scheme is running for about the next month, and then we'll be able to reflect kind of early in the new year where that leaves us, what gaps we've got, and what that means for those members of staff remaining. But the transition process that we've talked about since March is really well underway now, and it's really gathering pace. That would be my assessment. I think my only other reflection, which is also mentioned in the report, I am pleased that the operating model we proposed and the structure then that we're now consulting on does fit very nicely with the strategic commissioning framework that's also been published since the last board meeting. So that's described in the report on pages 2 and 3. But those key functions that we are going to have to undertake, they're mirrored nicely and quite neatly in our operating model and structure. So lots and lots of change, but really gathering pace as well would be my headline. Just moving through the report, we're going to do a deep dive on urgent care in the next agenda item, so I won't dwell too long on that. I mean, I think in general, we do need a bit more traction in the urgent care improvement work in both counties actually, but actually a lot of the other performance indicators are doing reasonably well. So we're in good shape actually, as we're in the middle of winter, where we just finished another period of industrial action, which obviously is a massive challenge for operational colleagues. But people are bearing up well under quite some pressure really. But we'll cover some of that in the update that Mary will lead next. Just another couple of things. So the point prevalence audit for 2025, the headlines are reflected on page 6. Again, we're making further increases in the patients who are in the right setting. This is the 4th point prevalence audit we've done now. There's so much more work to do on this. This is such a big part of our strategic work together actually, really. How can we make services work better? How can we make delays and the wrong pathway being used an absolute minimum, and that really drives the efficiency and productivity and the experience and outcomes for patients. But yeah, we're making progress in the right direction, and I'm sure we'll have other conversations about the point prevalence audit and where next. And then finally, just on page 8, just to touch on local government reform, which I think is a really big issue actually nationally for the NHS. So lots of councils are now working on the first stage of local government reform, which is basically to introduce unitary local authorities. We're fortunate that Herefordshire already is a unitary local authority, so there aren't 2 tiers of councils in Herefordshire, but in Worcestershire we have a county council and 6 district councils. Lots of discussion in the media, lots of political debate over the course of the summer, but in essence 2 proposals have emerged for Worcestershire now. One to create a single unitary authority covering the whole county, and one to create 2 unitary authorities, one covering the north and one covering the south. So some of the details of that is covered in the report. I think for us as a system, it's important to reflect on the impacts of that on the health and care system, and particularly the ability of our teams to interface properly with upper tier authorities. Because of that, I have engaged with both parties, both developing the 2 plans, and I've represented some reviews on behalf of the system, obviously keeping in touch with Steve and Ellen and others to make sure that we are being as constructive as we can. It seems as though those proposals are going to be submitted at the end of this month, and then feedback does look as though it's kind of early summer next year, so it will take a while for us to work out how that plays out. But I do think it's quite a significant development in terms of the wider health and care system. And then just a final point, the report does touch on GP out of hours procurement, which has been a really exhaustive and detailed process that David has led as our senior responsible officer. We have a confidential session at the conclusion of this meeting where we'll be making a decision, hopefully, on the final outcome of that procurement process. So thank you to everyone who's put the work in on that, and we'll discuss that in the confidential session because of the commercial confidentiality nature of it. So, Christine, I'll stop there and happy to take any questions.
Thank you, Simon. Open it up for questions then for Simon and indeed colleagues who might want to support his responses. Any questions or comments? Nigel?
Thank you. Thanks, Simon. That's a really comprehensive report. Really good to see lots of stuff in there. The bit that I just wanted to highlight was a bit of really good news, I thought, from the bowel screening backed up with seemingly we are doing exceptionally well, and I think that that will translate into better outcomes and saved lives. So I think that should be celebrated, and it'll be very interesting to see how that translates in the years going forward, how that translates into better outcomes, better life expectancy, and better cancer survival.
I mean, Christian, I would just agree wholeheartedly. Screening programs are really important. We've made quite a bit of effort on screening programs in the health inequalities work. So when you look at health inequalities at ward level, some of the big inequalities are in cancer outcomes. And when you look at screening uptake in those areas, it's lower than other areas. So it doesn't take a rocket scientist to work out that actually, firstly, let's focus on getting better screening uptake. So that's not the whole story behind bowel screening, but some of it has been quite targeted intervention at very local neighbourhood place level. And I think that's really, really important. You're right, Nigel, we don't see the benefits of that immediately, but hopefully over the next 10 years, we can start to see much better cancer outcomes in those areas, because screening will pick up these diseases, these conditions earlier, and we can intervene earlier. So no, thank you for raising that, Nigel.
Thanks, Simon. We have several more comments. Rachel, please.
Oh yeah, thank you. And Simon, again, a great report. I mean, there's so much going on, isn't there? And there's a lot in there, so it's really good to see. But I just wanted to pick up on the building a sustainable future, and I'm really glad to see that we've had a refresh of it and we're doing more work on it. But I'd like to know a bit more about how we're going to develop the outcomes and be clear on the outcomes and the impacts of that, and how that's going to feed into our medium-term planning that you've talked about in your paper.
Yeah, thanks, Rachel. I mean, we had a bit of a lock-in session on a Friday afternoon a couple of weeks ago here that Stephen and some others were at. Really good conversation. I think the trick with our Building Sustainable Future work is going to be to make it survive some of the policy changes around us. So obviously we started this with a very system-wide focus. We're moving into an era where kind of commissioning is becoming important again, and what is the commissioner going to do? And Krishni and I think, are both determined that as we make that transition, we will keep hold of the system collective approach, and I think that's really, really important. I mean, you're right, we talk a good game on building a sustainable future, don't we? We're doing all the right things, but as we enter into this medium-term planning process, we have to be able to quantify some of the benefits of that over this 5-year period. So I would see some of the programmes, I mean, long debate, Mary mentioned stroke in the patient story, long debate about stroke services, but through Building Sustainable Future, we need to get that programme over the line, we need to finalise the business case, and the outcomes, both financial and patient outcomes, need to feature in that medium-term plan. That's the test, isn't it, for all of those areas of work. But look, I'd expect us to keep working with the board, to keep working with the finance committee, because those big system-wide changes, yes, they do need to be supported by organisational level efficiency and productivity, but these big system-wide changes are the added value that will help us get that underlying position down. But I would expect to see our ability to quantify some of that in probably years 2 to 5 of the medium-term financial plan. That will be really, really important. So again, thank you for raising that, Rachel. Really good point.
Thank you, Simon. David, please.
Thanks, Krishni. And Simon, I echo what everybody else has said. It's an excellent report and so much going on, but really clear. So thank you. Firstly, I wanted to say I kind of welcome that collaboration you talked about between the sharing of resource across the West Midlands ICBs. I think that's clearly the way to go forward. But my question was more around the announcement about funding of redundancies. Does that mean that we can actually speed up the kind of giving clarity on the new structure and actually getting our new forming and getting our new structure in place? Can we speed that up with that new clarity?
Yeah, David, thank you for that. I mean, we've basically been given somewhere in the region of £12 million across the two ICBs to fund redundancy costs, which it's not as much as we asked for, but I think it should be enough to really accelerate this. I think my only caution is I want to get the structures right. So yes, there has got to be a pace, but equally, I want us to make sure we're building a structure and an operating model that evolves, that's going to enable us to do the job. I still think there are quite a few unknowns within this transition. So I've read the strategic commissioning framework. I'm confident we can do all of that. The big unknowns really are still around the things that supposedly NHS England might be taking off us or they don't want us to do anymore. And I think there's still some big question marks around some of the coordination around digital strategy, some of the workforce planning that aren't in the strategic commissioning framework. And strictly speaking, we don't need to do anymore. But I think we'd all appreciate, because we talk about them in these board meetings, actually the value they add. So I still think there's a bit of a way to go to really determine the job in hand. So I think that's probably the biggest limiting factor on finalising this. I think the funding has certainly removed the financial constraint, because it will allow a big chunk of change to happen early in the new calendar year and before probably the end of the financial year. I think we'll probably through the summer have to then finish off these final bits about just being crystal clear around what is it the ICB is really required to do in some of these areas. But we'll work with the transition committee, with the board, and obviously with the new board structures that emerge in the new calendar year to make sure we get that as right as we can.
Thank you.
Thanks, David and Simon, for responding. Stephen, please.
Yeah, just more of a comment, really. I think we're in one of those phases, aren't we, where it doesn't matter where you look in the whole health or social care system, there is something going on. There's a lot of change, and that creates a lot of uncertainty. And I think we have to be really cognizant and together on the messaging that we're giving. So as a kind of live example, when it was announced around the ICB programme recently and the NHSE one, I had staff coming to me going, does that mean it's affecting us in the trust, and the things like that? So people are connected like that. And I think the other one I'm really cognizant of as we go through this is around the patients and the public, because for us in it, we kind of understand the system, but it can be complicated as well. I think it looks even more complicated and scary when you're looking at it from the outside and you hear all this. So I think there's just something for us mindful as we go through that, given how much change there is. But I think if we just keep that and think of those communication channels we've got areas like Health Watch and others. I think we've got to take the public with us, because I think it could look a bit scary from the outside of what we're talking about, but the right thing to do, I would say, just in my view.
Yeah, thank you, Simon. I'm sure, thank you, Stephen, and I'm sure Simon would agree. It is really important that we understand that, that there's a lot going on, but the important thing is that ultimately we need to still continue the day-to-day focus on delivering safe and good quality care for our patients and our communities, and I think getting that balance right is important. So absolutely need to make sure we have coordinated messages across our system, really. And I think that's why Simon and I are really keen that sort of collective sense of effort into everything we do, which we've established well, I feel, in Herefordshire and Worcestershire, needs to continue, because it is the relationships that oil the wheels of us communicating better together and doing all those things together. So it is important that we continue that. So thank you, Stephen. Paul Walker, please.
Thank you, Krishna. I mean, just a couple of things for me, if I may, just to kind of build on Simon's report. And I think particularly kind of the 6 months end review. I was particularly pleased to kind of see that the outcome of that review report, and I think thanks and say Mary's blushes here in terms of the work that Mary and Jade Brooks have done alongside Liz Farr and Hilary Jones. Kind of exceptional in terms of taking what was a good report in the first instance on to the next level, particularly about the work they've done around waiting list, around speech and language therapies, and addressing that particular spike in the kind of the work on autism and the support while you wait feature that's been introduced, and kind of the building capacity and capability with new links into Birmingham Children's Hospital, and a kind of real focus on co-production now, and using the work that the family feedback sessions are in place with children's services. So that, I think that's something really to be proud of in terms of that service and the progress that's been made, and time to kind of give that a shout out. I'm particularly pleased it's in Herefordshire, but clearly it's about where the opportunities are in Worcester to kind of pick up on that element of good practice, so it works across the system, across both counties. So I thought that was a worthy of a shout out, and thank you to Mary and the team for that. Just a couple of things just to add to that from our perspective. We're currently in our 3rd week of a full ILAC re-inspection of children's services. For those of you who've been around as long as I have on children's services, we are currently inadequate in intervention. You know, we want to lose that label through this full re-inspection. A lot of work happening across the system. So we are in the 3rd week and things are going well at this stage. The day-to-day feedback has been positive. So we stay optimistic as to what the outcome might be, but certainly as a minimum losing that inadequate label, which is something that the staff and the team are working really hard at. And secondly, we went through our inspection of adult social care in September, so it's probably going to be early in the new year where we get the full report in terms of adult social care, and again that will be of interest to the board probably in the new year, Krishna, in terms of where we take that and the findings and recommendations. But as ever, we remain optimistic in terms of the quality of practice that's consistently applied across the service there. And then the last one from me is kind of it's that time of year for local government settlements. You know, the Chancellor takes great pleasure in releasing that on the last working day before Christmas. So the early noise is that's not going to bode well for county unitaries at a time when we've got a considerable increase in demand across our adult social care services. So some of that work that we've started, not least around joint commissioning, particularly with our partners in the market, where we can work together as to how we address that, and other opportunities through different and better use of the Better Care Fund will come to the fore as we move forward into the next financial year. I know that's beneficial for both parties, but given the increase in demand we've experienced, which again I think is the potential for an item to come back in the new year to better understand the root cause of the increase in demand and how that's being tackled is so a combination of here and now issues, Krishna, and some things for the new year.
Yeah, thank you, Paul. That's really helpful. Simon, did you want to comment on how and when we might be able to bring those back?
Yeah, I think some good points raised by Paul, and actually when you take a few steps back, the journey of improvement, particularly in children's services in Herefordshire, is a significant success story for the system. It's not directly related to a lot of the other things we talk here today, but it really is important for young people and children in Herefordshire, and it really is important actually for the wider system in so many ways. So Paul, quite rightly, should be really proud of his team's efforts. I'm glad he cited Mary and Jade's contribution, because we feel we've really gone above and beyond to try and do everything possible to help and support this improvement process. It's a great example of partnership working as well, isn't it? And yeah, Paul, the adult social care inspections, yours was earlier, Worcestershire was last week or the week before, so we should have in the new year outcomes from both of those, which I think will be really interesting. And again, I'm from what I've heard from talking to you, from talking to Paul Robinson and Mark Fitton in Worcestershire, I think the early soundings for both of those are quite positive. I think it should give us quite a good readout of where we're at, and hopefully it gives us some areas we can further improve on. But I'm not getting the sense that either of those inspections are going to give us a particularly negative outcome. So it should be a good reflection of the work we've done over the last few years in both of those areas.
Okay.
Great, thank you. And Hannah, if we can just pick up that we'll need to make sure they feature in some way, whether it's through Simon's report or whether it's through another mechanism, we'll just perhaps reflect on. Yep. Thank you. Roy, please.
Yeah, thanks, Simon, for the report. Lots to celebrate in there. It was just to pick up on the general practice contractual elements. I think you said we're one of only 6 ICBs to achieve that, which is obviously positive. And it's really, I think, a reflection of sort of the quality of general practice locally, but also the way we are starting to work differently, moving to a modern general practice approach, using more triage. And I think that's good for patients. And as you know, our patient feedback is some of the best in the country. But it also means that we're working differently. And I think later in one of the reports, there's a talk about our appointment numbers may not meet trajectory. And I think we need to recognise that actually appointment numbers no longer reflect the activity in general practice in the same way that it used to. And I think that's important for system partners to understand. Actually, up to 40% of our activity will now be done through triage, and that may be sending prescriptions or messages or support or signposting, and that won't be appointments, but it's still better access. So I guess it's, I know that as part of the neighbourhoods, the NHS England are very, very keen on improving GP access, but we shouldn't think of that as just giving lots more appointments, because that's not actually necessarily the best thing for patients. And we should be thinking about, I guess, a smarter way to measure access. And it's just whether you've got any comments on that.
Yeah, really good point, Roy. I mean, we had the debate, didn't we, a couple of years ago about reduction in face-to-face appointments, and NHS England's view about how terrible that was. And well, not really, not if we can do the appointments more effectively and to an even greater deal with more people's needs through other routes. And actually, I think the satisfaction measure will continue to be the thing I am most interested in. It's useful for you to point out, Roy, the contract changes, because you're right, there are 6 ICBs who declared 100% compliance with those contractual changes. We were all audited then by NHS England, and actually the other 5 were found to have some omissions and errors, but not Herefordshire and Worcestershire, pleasingly. So there is an argument we're the only ICB in the country that is 100% compliant with those new contractual changes. But that is all credit to the teams and to Rory and Nigel's colleagues who have embraced what have been quite a difficult and controversial set of contractual changes this autumn, haven't they? It's a real problem. It's nowhere. I think Coventry and Warwickshire is at 77% as of yesterday, so still got quite a long way to go. We got 100% compliance on the 1st of October here, which is something to be celebrated. I think we're so far ahead of the curve on modern general practice and general practice transformation that I'm not sure always the national and political metrics are keeping up with that pace of change. What's important for us, I think, is that we try and just protect and maintain those high standards, and almost our own local assessment of where we are, I think, in this instance, is much more relevant than some of the fairly crude national indicators. But yeah, Krishni would agree with me, I'm sure, that volumes of appointments is kind of irrelevant, really. It's about the patient outcomes and how satisfied the patients are with their outcomes. That's where we will always start our kind of performance appraisals, definitely.
Yeah, definitely support that, Simon. And I was smiling because it was a point of debate with the former NHS England chair that I raised previously, because we were being held to account for face-to-face GP appointments, and it seemed counterintuitive, really, to the digital agenda and all the other things that we're talking about. So I'm totally supportive of that. And interesting, I was going to pull that out as well through. I think there's much to celebrate in the reports. I do want to say thank you to all the colleagues who've pulled that together and made those improvements happen, because there's a lot of really positive things, not least also the progress on work and work and health and housing and health, which, you know, these are important areas of focus for us. As well as the point prevalence audit, you know, so many good things in that report. I did interestingly come across a Ipsos survey that's done every 6 months. So this is, I think, a different survey to the one that obviously pulls together our data about our community's satisfaction. But the interesting thing, the Ipsos survey is on the NHS and it's done every 6 months, and improvements in access to primary care are the #1 thing and have been for a very long time. So I think Simon, you and I have talked about this. It's really important that we make sure we get the message out about the work that we are doing in primary care, which is increasing access and is providing a more satisfying experience for quite a large number of our local population. Clearly, we recognise there's some variation, isn't there, that we're addressing through programmes of work. But it is really important we get that messaging right. So I did want to highlight that. I will come back with one final question, but Vicky, did you want to come in first?
Yeah, it was just to explore, thank you for the report, Simon, just the WorkWell process that's been put in place. We had really, that's I think just over a year, we had a bit of a slow start while we were recruiting some of the health advisors, but that's such a positive outcome from all the work that's been put in. I guess I was interested in terms of what you referenced at the beginning, the strategic commissioning framework. It says in your report that we'll have more funding to carry that on for the short term. How that then transfers across to that strategic commissioning framework for your consideration, because there seems to be sort of two processes: national funding and then the commission framework, which is having to work quite quickly in terms of your next submission.
Yeah, I mean, Vicky, good point. I mean, I think the simple answer is they don't really correlate, because things like WorkWell aren't part of the strategic commissioning framework. It's not really in that document. It's not really seen to be our job. But clearly, and it kind of reinforces my point, that there are a lot of things still to be confirmed around really where ICBs will land. I think, and I've been a bit involved over the last couple of months with the West Midlands Combined Authority, because Coventry are a member of the Combined Authority. Combined Authority have a devolution deal which is all about economic growth. And I think the NHS for a long while has missed a trick really in not being clear enough about the contribution health can make to economic growth. And WorkWell is a brilliant example of interventions and support we can offer to people that help them feel better and help them basically re-enter the workforce and then to be productive and to be part of an economic growth plan. And the Combined Authority are really interested in this. I've kind of majored on this, and they're all over it. And I think we should be doing that similar focus in Herefordshire, Worcestershire and Warwickshire as well, because we can make a massive difference to hundreds of people. We can get them back into the workforce that supports then how, them taking up local employment opportunities that support their contribution to society. I think generally we should be making a lot more of that, and whether it's in the strategic commissioning framework or not doesn't really bother me. I still think it's the right thing to do, so we should be doing that. So it's a really good point to bring out, Vicky, and a great way of demonstrating, yeah, we'll do the day job, we'll do the strategic commissioning stuff, but there are a whole load of other really useful good things that need to be done around that, and this is one of them without a fragment of a doubt.
Yeah, that's great. Thank you, Simon.
And indeed, our 4 aims are still there, aren't they, from the Act that came into the fore, and it still fits with that. So I think we hold on to that, because I think the 4th aim is all about our, I can't remember the exact words now off the top of my head, but it is all about our contribution to the wider health and well-being, the wider economy, and the wider economy, I think, of the local area. Sarah?
Sorry, it's just on the back of that really, and just with it being my last meeting, I just say it's incredibly positive to hear your enthusiasm on that, Simon, and the way that you talk about it. I think, you know, when ICBs were set up, this was one of the things that drove a lot of us to think this is a moment for change. You know, we see that come and go, and we've got to hold on to our hope and enthusiasm. So it's really positive to hear you say that. The way that working with the combined authority can play a part there to really acknowledge the wider determinants of health. So as you say, do the day job, do it well. Like we heard in the patient story, you know, when someone has a stroke, the NHS's responsibility is there to manage that and manage it well. But not forgetting the wider determinants that play in as well in terms of the economic growth and other things. So I guess it's back to you and to Krishni, when you're in your important meetings and you do meet with ministers and things, then actually it's helping national government as well to potentially see that the Department of Health needs to talk to the Department of Justice, work well coming from the Department of Work and Pensions. Actually, this is part of a bigger picture, and we've got a part to play, and I think are playing a really positive and significant part. But I think it's that chipping away, keeping going, and it was just, yeah, I think several years down the line, really good to hear that that's still a real positive intent of the ICB. So thanks.
Thank you, Sarah. Nigel, did you want to add to that?
Yeah, I just wanted to just add a little bit about it. I think there's a great opportunity here for, you know, absolutely, I think, you know, work well is good for our communities in all sorts of ways. But I think there's a health opportunity here, particularly in looking at some of the cohorts. And I think if you look at things like mental health in young adults, which can lead to sort of devastating life implications as people fall out of work and fall into more serious mental health, actually intervening at a neighbourhood level, and that I think there is real scope for sort of integrated neighbourhood teams, which would involve work well, because I think it is such an important part of, you know, our core health business as well as sort of wider health.
Absolutely, totally support that, Nigel, and we need to be thinking about that in our design, really, of our neighbourhood health approaches, don't we? So all very supportive of that. Simon, one last question. I'm conscious your report has quite properly, because there's so much in there, and it covers a wide range of different things. I just want to check, Simon, obviously there are a lot of deliverables that we as an ICB and partners actually need to provide to NHS England in a relatively short, I suppose, over the next 3 or 4 months, not least around the 5-year commissioning plan, but also the medium-term planning submissions. I'm just conscious that we're going through, you know, a transitionary period with some challenges in terms of capacity anyway, with winter and everything else. How confident are we that we can meet, you know, all these expectations and deliver a transition and keep a focus on winter? I know that's I know that's what we're the challenge we've set you, Simon, and it's perhaps your day job, but I just wanted to kind of get your sense of how confident you feel that we can do all these things in a managed way.
Yeah, I mean, it sounds a bit scary, doesn't it, actually, when you say it like that? Even I'm starting to doubt myself now. But look, in general terms, we've got great people, we've got good processes, we've got great relationships. Those are the things we will fall back on to kind of get the job done. I think it is going to be a challenging 4 or 5 months, but actually, my anticipation is that we use some of those foundations that are in place that are really strong to get what needs to be done. I think the planning process, we've got pretty well established routes. Mark will talk in the finance report. We've had some of the allocation information, but not all of it. So we've been working on the planning process for a few months now. So I think it's just a case of taking that through the next couple of months to get to an endpoint. I think the transition is really tricky and really difficult, and I think the voluntary redundancy thing is a different factor now that lots of people will be thinking about their futures. What's important though is that anybody that we are allowing to leave on a voluntary redundancy basis will have quite a long notice period. So most people's notice period is at least 3 months. The director's notice period is 6 months. So actually, we will look to use those notice periods to give us the stability that we need over these next few months. What matters whilst we're doing that process is that we're really embedding a new way of working, a new operating model, a new role. Krishna, you and I are both now working across 2 ICBs, but we're the only ones. We need more people to be in that space who are understanding this bigger perspective. So, you're right to point out there's a risk because of so much work, but I'm pretty confident that we've got the right people and the right approaches that will allow us to deliver that. So thank you for raising that.
And I'm sure that colleagues around the board will want to support you and everybody else through that process. So I just want to say that. So Simon, thank you for your report. It did spark a lot of conversation, which and we are a little bit behind time, but I don't think that's a problem. I'm sure we'll make that time up. And better we use to really reflect on the range of positive things and challenges that we're facing at the moment. So we move on to the Spotlight report. So we come back to our theme, which is urgent emergency care, and we have a spotlight which Mary, I think you're going to lead for us.
Thank you, Krishna. So obviously, colleagues, we've talked a lot about winter planning and urgent care over the last few months. So I thought it'd be an opportunity in the spotlight to look at progress with the delivery of our urgent care strategy, which we signed up as a system in 2023. It's been a very quick 2 years. And the mission statement there is about us working together to achieve the best possible outcomes. And we know from evidence across the country that where systems work together collaboratively in a very complex, multifaceted, position of urgent care, they achieve the best outcomes. So that's what we're striving to do and do regularly on a daily basis. So the strategy derives a vision for the nationally best practice effective UEC model with our 6 strategic priorities. So this paper outlines the progress with some of that delivery of the strategy. And the method we've utilised is place-based and organisational-based improvement plans and system improvement plans as well, to make sure we've got an oversight of the whole system and what every part of that system is doing to improve urgent care. Also, I think we need to acknowledge that this urgent care strategy can't do it on its own. It's very reliant on other strategic pieces of work as well, particularly for our system, the frailty strategy, the palliative and end-of-life care strategy, and the neighbourhood health framework, 3 really important pillars of supporting urgent care to deliver the outcomes that we want. I think we're all aware that assessment and delivery of our strategy and performance, every organisation, every ICB in the country is being monitored on urgent care at the moment from a national perspective. And key to that is some of the feedback we're getting. You can see from their informal feedback that the experts believe we've got nearly all the pieces of the jigsaw together now for a good UEC system. We now need to be matured and ensure full delivery of our system and prepare for the future. So you can see on page 2 our ICS UEC model. It's got 2 big aims really. Getting the public to the right urgent care service first time, and we've discussed some of this already, haven't we? The A&E departments have a specific remit, and often we see patients in accident and emergency departments who their urgent care need could be managed and should be managed elsewhere in the system. And then when people are in our urgent care system, having best practice patient flow across the whole of health, social care, voluntary sector, everywhere, working to those best practice standards to flow patients back to their own home where that's appropriate. So a key aspect of our strategy is managing demand and preventing that inappropriate use of emergency departments. So obviously we're keeping our population as well and healthy as possible using comprehensive vaccination campaigns. I've just seen the latest data on our vaccination campaigns, and for both the public campaign for flu and COVID, we're doing well again this year. We're a little ahead, which is great. And even for the workforce, we're ahead of where we were this time last year. So we need to continue that journey to see the benefits of that. And obviously we're targeting neighbourhoods in our ICS where we know access to services isn't great. So we're targeting that through the work that David's leading in inequalities. So primary care is the first point of contact for our population, and Roy and Nigel have stolen my thunder a little bit on this, but quite happy with that. So you can see for the information that we do have very good access and for appointments to primary care. That's from our patients' perspective, but also in the data. And we've chosen to enhance that with enhanced access appointments and same-day urgent care hubs. Now, does that mean that primary care can see everybody that is contacting primary care at the moment? There are days when that's a struggle because there is a lot of demand on primary care, but I think we're in a much stronger position than other areas of the region, definitely. We are promoting increased use of our pharmacies and the work between primary care and our pharmacies to share information, and we're evaluating the impact of that currently to see how minor illnesses can be managed in those pharmacies, and they are providing some enhanced services. And obviously our urgent dental care appointments were commissioned this year, designed to prevent those patients. When I was an A&E nurse coming into A&E with a sore tooth, that's not what an A&E department is for. We want them to be seen elsewhere. Big part of our managing demand is having a good single point of access, and we've got single point of access responsible for coordinating all the care pathways across urgent care outside in hospital, but also outside of our hospital. And as of they're working well. They can develop more, there is no doubt about it. We can mature them more and develop them more and give them more of a remit to really reinforce using out of hospital services where appropriate. We've started with 111. The 111 pathway into our single point of access is there in both of our systems now. And if we get this right, we can reduce the 111 to ED attendances by up to 4%. We started earlier in Worcester. We've seen a 1.5% improvement since last year, but we've got a long way to go this winter. But we're constantly reinforcing 111 with our 111 to use our services. Equally, our ambulance partners, getting the ambulance crews to use this single point of access is a challenge which we continue to work with them on. So maintaining our frail patients and high users of services in the right setting. We know from our demographic work that the challenge we're going to have in the particularly over 80-year-old population in our system, the large number of care homes and nursing homes, residential homes, with more being built at the moment, which is obviously a concern for us. And we know that keeping those individuals in their own home well is best for ageing well. So what we're doing to try and support that positive ageing experiences. So our clinicians in primary care are implementing what we're calling capacity and access improvement initiatives, really stratifying those patients and seeing where continuity of care would benefit. Because I think some of that has been lost over the years with different contractual mechanisms. I think getting back to continuity of care for those individuals with a clear plan is the way to keep them well and out of hospital. We're just about to sign off and launch with all of our care homes a very simple resource pack. It's called a deterioration pack. It's not the greatest word, but it helps those nurses and carers to know what to do when their frail elderly individual is deteriorating and who to contact rather than dialing 999. So that is being launched currently. We've enhanced our single point of access with a GP in each of them, so there's GP presence in each of them now to enhance that frailty attuned approach and try and reinforce the uses of services outside the hospital. And we've put resource into virtual wards in both of our areas to support reduce length of stay and admission avoidance. These are things that we do need to mature. I think these are probably the ones things that, and it does take time to mature these and to make them work. And Stephen talked, Joe, about the opportunities around digital support to these. I think are really enhanced and could be enhanced over the next couple of years. Actually, we've got a great stock of community hospitals across the system, haven't we? We're really quite fortunate, although everyone believes we've got too many of them. But there is a real opportunity to use them more for stepping up rather than using our ED for our frail elderly patients. And I'm aware both place-based systems are working on that currently. And we've got pathways that are very clear to support our system clinicians as to how to use that, use the frailty services. This is probably one of our biggest challenges going forward. I'd suggest colleagues, if we don't get this right and change, it's almost a cultural change as well as a process change of keeping individuals in their own home. Our ED departments and our hospitals are going to continue to struggle, and probably struggle even more than they are currently. Obviously, that leads us to the end of life period for our individuals. And we know with our demographic, 40% of our patients are deemed in a hospital to be at the end stages of their life. And we just signed off our palliative and end of life care strategy, which I'm happy to share with colleagues if I haven't seen it. And you can see from the paper what we're trying to achieve. We need to get back to really coordinated care for people in the end of life. Some of our ED audits that we've done this year have shown that we're not coordinating the care as well as we could be, and hence the port of call for the family or the carer and even the individual is an A&E department in crisis, which is not where any of us would want to be in that position or for our loved ones. So we're doing a range of interventions, and you can see the Neighbourhood Health Delivery Framework is a big part of that. We're instigating through primary care multidisciplinary team discussions about these individuals, and we are relaunching almost our respect documentation. And for the public, if they're listening, that's a plan that records a person's personalised recommendations for care in a future emergency at the end of their life. And we're rolling that out digitally. Once we've got the gremlins sorted out in the next couple of weeks, we're going to be rolling that out digitally to make sure that it can be shared across the system. It's really important that patients and their family understand and are communicated with about their end of life wishes and choices, and I'm not sure we're doing that as strongly as we need to do. So hence the crisis situations occurred. We've made a decision with through our strategy to enhance in our ED some specialist palliative care consultant or even nurse consultant resource at the front door to help to reinforce this cultural way of working. So we're hoping to launch that over the winter as well. And we're going to reintroduce our gold standards framework training. I think we've lost it over the years since COVID. We're going to relaunch the facilitation and the training of gold standards framework across our whole, particularly our hospitals and our community settings and our front home. So I think, with frailty and end of life, my view is, I'm happy to be challenged, if we could get that right for that population, we would see a much better urgent care system that met the needs of our individuals in a much more dignified way than we're currently doing. I won't go through children's, but there's a whole piece of work on children's urgent care as well. It's really about information to the public about what they can do. Mental health, in many systems across the country, mental health in ED is a significant issue. We are in the fortunate position. We do have some occasional individual difficult situations, but we have a strong mental health service that really responds well to emergency departments and gets people to the right place as quickly as possible. I think the next part of this deep dive is probably another one of the most important things. Again, from our ED audits and from our ICS urgent care board discussions and clinical feedback, some of the finding is that we really need to support our clinicians to make really good patient-centred decision making and to look at the risk that they're taking. I'm not suggesting that we're putting patients at risk. I'm just suggesting that the risk level is low, and hence ED department seems to be the safe place for a lot of individuals. So Will Taylor obviously has led a great piece of work across our system and with a workshop in September to support how we could do that for our clinicians and manage that risk safely and give them the tools that they need to support them in that decision making. So you can see from the paper what the workshop themes were, and it's positive risk taking, a culture of support for individuals and teams, and how they can make those holistic decisions. So we're going back to that why not home, why not today approach, and relaunching our campaigns about home is best and home before lunch, because some of the risk appetite is meaning that people are staying in particularly in inpatient setting longer than they need to. We are developing currently a clinical risk decision framework. That's not an easy thing to do, and Will's leading that work with clinicians across the system to give them a tool to help them in that decision making. And we're going to be, really supporting team reflection and peer support sessions to give them that confidence. And in next month, we'll have a big launch of the campaign that you can see some of the materials there to help us. It's the cultural side of helping an urgent care system, I think. Within our acute trusts, best practice, which we've talked about before, is making sure that we have, redirection to the most appropriate setting in acute, not always the ED, in a timely way, and that we have that best practice flow from our wards out to either our community services or to social care. We put a lot of investment through Better Care funds into that. We're not getting discharged to assess right every time. We're still working on delivering that across our system. But it is meaning that we still have high bed occupancy. We still have, we're struggling with our best practice performance metrics, and we're still reliant on the use of temporary escalation spaces in 2 of our 3 acute sites. Definitely, we've got that in place in quite high numbers. So we're constantly measuring demand versus capacity. Like the rest of the country, we have seen an increase in particularly walk-in attendances. That is a national phenomenon this year. Lots of debate as to why that is. It seems to be in the 20 to 30 age bracket that this is happening, despite all of the out-of-hospital access. So we're all working to really enhance that message to the public about not using ED as the first port of call. And you can see from the page 7, the data, we are still having a struggle, particularly, I think the ones to highlight are 12 hours in ED as well. So we have a large amount of patients waiting over 12 hours in ED, either with a decision to admit or even with not a decision to admit, and that is causing flow problems on a daily basis, and ambulance delays are again a feature of our system. So real summary of this is we need to continue to work together, despite all the changes we've talked about today, to agree the delivery of these plans, make sure that we're doing them at the pace that we need to do them. We need to reduce the bed occupancy to be successful, because clinicians are working in that high bed occupancy. It's very difficult to flow in a very positive way for our patients, and we need that clinical risk framework to make those good decisions in our system. If I was to say what were the top 3 or 4 things that are crucial to our system, I think it's call before convey, and from our ambulance, maximising the single point of access and the out-of-hospital services. That really good streaming at the front door of EDs to alternative pathways, because we need to improve that. And we're going to have in Herefordshire more SDEC spaces, more same-day emergency care spaces just after Christmas. That will be help the capacity there. And really getting discharged to assess from our wards, putting the patients first and getting them home and doing all the assessments we need to do outside the hospital. And our late in the day discharges, we have slipped back slightly. We're discharging very late in the day, which is causing flow problems. So I think those would be the top 4 things. But this system is complex, and we need to make sure that we're focusing on every part of the system to make the improvements that we want to see for our patients. So happy, there's a few hands up already. That's great.
Yes, quite a lot came up as you were talking, Mary. So we'll whip through them now. Nigel, please.
Thanks. So this couldn't be more important, could it? I mean, I think we're not going to get our system back on track unless we really get to grips with our urgent emergency care. And of course, there's so many facets to this, and it's so good to see the interventions that have been put in at all different levels. So thank you for the update, Mary. That's brilliant. I just had a couple of points, and one was to build on Roy's point earlier. I think we do have strong general practice. We want our GPs to be having those complex discussions with patients, which will guide their choices when you come down towards a crisis. So that's people practicing at the top of their game, planning, discussing with families what's important with them for them. So there is some work, Bridging the Gap, which is a GIRFT document, which looks at responsibilities from different partners. And I think we should look at that just to be clear. What we don't want to do is general practice picking up a lot of system admin rather than practicing at the top of its license. So I think that's and on a day-to-day basis, that's probably still happening. So I think if we can get our GPs and primary care teams practicing at the top of their license, having the discussions that we need them to have with the right people, rather than picking up admin from other services. It's not quite as simple as that, but the GIRF document goes into a whole lot of things, and there's a sort of requirements on general practice to up their game around referrals and things as well. So I think that's a really good thing for us to be looking at. Second point is around that data, and you alluded to that, and I think there are some really good examples around where they've got really good live data which is helping systems respond in real time to patients' need, looking at particular cohorts and tracking them through the system. And I think we need to up our game with that, and I think we need to be on top of that. And then also with our sort of aspirations, I think we need to be looking at them moving into a more proactive data space where we are now starting to predict those people who are going to become unwell, because the technology is there. We can join the data up, then AI can start identifying people who may be an issue or may be coming in towards their last year of life before we're picking them up in crisis further down and being reactive to it. So I think that's a hugely important area, which we just need to make sure that all our digital data streams are aligned and targeting, because I think that's going to be a real, if we can get that right, there's no reason why we can't. I think that'll have a huge impact.
Thank you, Nigel. Mary, can you comment briefly on that? I mean, have we got the checklist in use that Nigel?
Yes, I mean, bridging the gap we have looked at. I mean, have we done enough on it? No, Nigel, we haven't. We need to do more work. I do agree on that one. The data and the single point of access, we had this conversation yesterday, didn't we, Nigel? We are going out, starting in Worcester next week, into the single point of access, and to come back with recommendations of how we can get to best practice on this, because our data is I think a lot of it is there. You're right, Nigel, we're just not joining it up enough to have and to make use of it in our single point of access. So I think that is really important. But I welcome your input into that and these visits. I know Roy's coming to the Worcester one. We'll do the same in Hereford, and then bring it back as a collective of what we can do in this next stage.
Great, thank you, Mary. Vicky, please.
Thank you, Mary, and firstly thank you for your leadership on this, because you are so over everything that's happening in urgent and emergency care. It's amazing. But I think you've really helpfully outlined some of the key areas that need to progress in terms of making that difference that you want to see, or we all want to see. But I guess the clinical risk framework sounds really key in the middle of that, and I guess the question is for yourself or for Will is just how can we support that as a board, because we obviously need to stay very close to this in terms of outcomes, but actually how we're progressing on all of the matrix that you've outlined, just what we can do about that.
Well,
yeah, so the clinical risk matrix I think is really, really important. So what's really clear is what affects risk, and some of it's about how we structurally arrange ourselves, and that's what we often talk about. But what really affects how patients flow is about the individual decisions clinicians make on the ground. And interestingly, I mean, I sponsored a piece of work through the West Midlands Clinical Senate last year where the clinical fellows looked at this and produced a really good paper called Reimagining Risk. Our threshold for risk management drops as we get more stressed, so we end up actually trying to make safer and safer decisions for us as clinicians, not necessarily for the patients, which actually is an interesting concept, because some of the decision making then puts people more into hospital because it's perceived to be a safe space, where actually it was better for the patient to be in their own home. And the things that drive that are not having a really coherent team around you, not having good senior support, and not understanding the facilities and the things that are available and trusting in the community. So what we want to do is put in this clinical framework that really enables people to understand what we can do to support them to make the right risk changes. So part of that is thinking well about what you do, thinking an awful lot about respect, and really good respect. And we are tying this into the respect launch as well, because it overlaps. But there's some really, really key messages. One will be your team has your back. And that's a cultural thing we need to embed. So, it's no good chief executives and chief medical officers writing letters saying we have your back. That doesn't work. It's about your team having your back, having visible senior support right near you, and really pushing things like what we're calling the rule of 4. So the decision you make about the patient in front of you affects 4 other patients. The inpatient who's deconditioning in a hospital bed where they could be better off at home, the patient in ED waiting for the bed, the patients in the ambulance crew outside the ED, and the patient waiting at home for an ambulance. So really impacting that you're not just looking at the patient in front of you, you're looking at 4 other patients. Now, what I think would be really good in terms of the support of that is a lot of this is about working with clinicians on the ground and their immediate supervisors. And that's in nursing homes, it's in ambulances, it's in GP practices, and it's in hospitals. So really, we need just to create a bit of time, I think, in what is a busy time of year to do that piece of work with them.
Thank you, Will. I think, you know, this highlights why it's difficult to change, isn't it? Because it is a sort of cultural behavioural thing, and that's not a criticism of individuals. As you say, Will, this is about the environment in which they're working and all the things that impact on people's judgment, really. But it does sound like a really important piece of work, and obviously, as Vicky said, anything we can all do to support that. Please do.
It's been picked up quite a lot because nowhere else is really doing this, and so I've been asked to present it at the regional clinical lead A&E group as well. So it's quite a lot of interest in see how we do with this and whether it can be extrapolated.
But certainly tools, I think, do help, don't they? Because it gives people that structure to work around when they're under pressure to make decisions. So it sounds like a really good initiative. Thank you. Amma?
Thank you. No, I just wanted to echo what everyone has said, that, you know, the report, it's very positive, patient and centric initiatives are being highlighted in this. So I think just wanted to echo that. To be fair, my question was around the clinical risk framework and the cultural change that's needed, and how we kind of, you know, increase that clinician confidence in the shared risk taking. So I think Will has covered that. But I suppose, Mary, I was going to ask you, you kind of highlighted your key priorities, and there's a lot of stuff going on. So, you know, from your perspective, what are the key risks that you think could impact, these interventions having the positive impact on our patients that they could have?
I mean, Stephen might want to come in on this as well, but, you know, the transformation, the time it takes to transform pathways and to embed them and to make them work, it takes a lot of time. And when you're in daily challenge of demand and, you know, escalation all the time, it's really difficult to really have the space to work with clinicians and managers to make that change and embed it. That is one of the biggest risks I think we have. We talk about winter, but it's all year round, the challenge and the work that we have. So I think that's one of our biggest challenge. I think if demand continues to grow at the pace it's growing currently in the last few months, that is going to be a big issue for us. We can mitigate that if we discharge earlier and do discharge to assess. We can mitigate that, but and I think some of this is the clinical risk discussion we've just had. Some of it is the processes just aren't really defined enough. It is the time and the space to put that in place. But Stephen might have, from a provider point of view, a different view on that.
Stephen?
Yeah, I think Mary is right. There's one of that, the business as you're trying to do it can be difficult, and I think trying to change the mindset, the culture while you're trying to do that. Both trusts have a number of things that they are doing as well to try and improve it. There's an awful lot going on. I think the other bit we just have to be careful of in this space is there's a danger that we layer on and sticking plaster. So actually, if you look at some of the diagrams, sometimes, and I'm kind of increasingly with some of the other trusts that are really good at this that we've been talking to recently, is I think you have to strip some out sometimes, and it can feel counterintuitive, but I think you have to do it. I think there's another piece of work that I think will be really interesting that Mary and I have been doing, is if you take all these services and you do a 24-hour timeline, it's amazing the drop off that you see that we kind of instinctively know, but at 6-7 o'clock, all those things that you used to be able to do have suddenly switched off. And then what we see in both trusts is it builds up through the night and we get a problem through, and that's kind of a cycle that we've got to find a way of breaking out. The other bit I would say is I think it's really important we stick together though, because it can get spiky and it can get a little bit finger pointy and it can feel like, is everybody feeling it the same? I think, Mary, you might say, I think we've made some real progress on that recently. Like I think it feels like we're not trying to just shunt work from one onto the other. It's got to be a proper system looking at it. But that's my risk, is we're going to overlay it, and then if you're a clinician in the middle of that, it's just impossible to work out where do I go, when, 5 o'clock, 6 o'clock, whenever. So I think that's the trick for us as leaders.
Thank you, Stephen. And it is a leadership challenge, isn't it? I mean, these are so many complex and so many variables in all of this. It's not so I think the leadership we all show collectively and individually in these moments is really important, and consistency does help, I think, as well, as I think Russell's pointed out in one of his comments. Okay, I'm really conscious of the time, so just be fairly quick in taking the last 2 comments on this. Roy and then Rachel, please.
Thanks, Chair, and yeah, thanks, Mary. Mine'll be a quick point. I think it's this is really good work, and I've come back full of enthusiasm for neighbourhoods and the possibilities, because we've been to a visit to Washwood Heath in Birmingham, and my reflection on that visit, and also some of the accelerator work we did around frailty, is I think we often underestimate the importance of relationships in this space, and actually that sort of trust between a clinician that you know handing over a patient compared to a clinician you don't know, it is a big difference. And the risk summit that Will run was really, really good. But it was one of the things that came out is almost, and I think it probably applies more to Worcester than Hereford, and actually trying to do this on a county-wide scale may not allow those relationships to build up, but I think doing it at a PCN scale is probably not right. And in Washwood Heath, they've gone for populations of much smaller, around sort of 225,000, and they are developing a real ownership of the patients within their patch between organisations, and they are building relationships, including with the ambulance trust and acute trust, and those relationships are allowing that increased risk to be taken between professionals. That I think possibly was some of the reason we might struggle in Worcestershire, because we're trying to do it at a larger scale. So I know we're going to be talking about that later, but it was absolutely, I think, the key to it, that feeling of ownership, but also working as a group of professionals that sort of had a handle on those patients, the data inflows, and I think that really struck me. So it's just to sort of add that into our thinking.
Thanks very much, Roy. Mary, brief comment?
Yeah, I couldn't agree more, Roy. I think the case management of some of these individuals with a strong team is really, we've got to get back to that. I think that has been lost over the years, and it's the reason when you look at ambulances outside that the ones that don't really need to be there, that they're a long time, they could be definitely managed by that situation. I agree.
Thanks, Mary. Rachel, finally.
Yeah, thank you. Yeah, I just wanted to say I haven't ever seen such a set of complex actions and stakeholder interdependencies set out so clearly and transparently before. So thank you for that, Mary. I think that's been a fantastic paper. But I think my question was a bit of building on the bit of a theme that we've been talking about, because we've already got increasing levels of demand with flu and COVID, and it's going to continue as you've quite rightly said, Mary, throughout the winter and beyond. When things get difficult, which they're going to get more difficult, aren't they? How do we, as leaders, keep that collective approach to working and, working and our interdependencies together throughout those periods of escalation? Really, that was my point. We might have talked about it enough already, but it might be one we want to come back to at some stage.
Thank you, Rachel. I mean, Mary, if I could add to that, I think it would be really helpful. I don't want to kind of overburden you and colleagues on this, but I do feel one of the key messages we got as chairs, and this is all chairs, trust chairs and ICB chairs, talking with Penny Dash recently, was just all of us keeping close to what's happening over winter and the winter plan. And it sort of builds a little bit on what Rachel said, not to start creating blame or anything, but to provide support, to understand collectively what's happening, and that sense of the board really being cited collectively, so we can do what we can to support this. And I think that was part of the winter planning process. I just wondered how you can keep us sort of, not you personally, but how we keep engaged with this, so we're not just coming back to talking about winter in February and saying, oh well, some of the things we said we were going to happen didn't happen. You know, how are we going to keep on top of it, really, because it feels really important this year for us to do that.
No, I think it's a really good point from both of you. I think, you know, from the board perspective, I think I did say at the development session, starting at the beginning of December, you'll be getting a monthly update of progress, big issues, etc., that we can use as key messages across the system. I think they're between, you know, across the ICS, between Stephen's organisations, Ellen's organisations, ourselves, we're in daily, hourly contact sometimes, working very closely on the delivery of the plan, and we have several good forums that we work together on. I go back to the ability to deliver this at pace is a challenge. There's no doubt about it, because of the constant pressure, and we continue to talk about how we could maybe even more collectively use our resource to do the transformation. That's difficult because there's lots of competing other things like operating planning and 5-year strategic planning, but this is so important that we do try and work together as much as we possibly can. Stephen might want to comment on that to finish off.
Yeah, no, I completely agree, Mary. Really, I think it is a constant challenge, and the other bit I would put is there is so much scrutiny around it now. That takes up a lot of time as well, because we're in that period of it. So we've just got to figure out a way of how we kind of keep it going and do those cultural bits as well.
Yeah, thank you, Stephen, and thank you, Mary, and everybody who supported that item. I think it was really important to give it the airtime. We all know that this is a massive challenge for us. It's a collective endeavour, as we've described, and I think the report has been really helpful. And really, at this stage, we are just asked to note the progress with delivery of the strategy and obviously the challenges we're facing. But I think as part of that report, Mary, if you can let us know if there's anything we need to do to support as a board, I think that would be really helpful. But we thank you, and in anticipation of kind of all the work that I know is still ongoing, we just want to thank colleagues who've put their sort of the pedal to the metal on this to try and get us as ready as we can be for this coming period. Now, I'm conscious we are somewhat over time, so I wonder if we could just have a slightly shorter break. We'll probably reconvene at 10 past, maybe a little bit earlier if we can, but 10 past at the latest, please. And then we'll whip through the other items as quickly as we can. Certainly, if we, having covered urgent and emergency care, then the quality and delivery report can probably be shorter on key points, Mary, that we haven't covered already, and we'll pick up then the remainder. So thanks, everybody. We'll take a short break, as we've said, so back absolute latest, ready to go by 10 past, please. Thanks very much. Okay, welcome back everybody. So let's make a start on the remainder of our agenda. So we're on to item 10, which is the system quality and delivery report. So Mary, obviously we've covered UEC heavily, haven't we? I wonder if we focus on the other aspects that you might want to highlight. Thank you.
Thank you, Krishni. So there's just two aspects in the report that I want to highlight to you, and happy to take, Kath and I are happy to take any questions. So building on what was said earlier about SEND and children and young people, so we are aware of our continued difficulties still within Worcestershire around children waiting for very long extended periods of time, largely for neurodiversity assessments. What we have now got in place for Worcestershire, just to give some assurance, is a 3-stage plan of increasing capacity, outsourcing for right to choose for these individuals and their families, but also an early intervention model that we're doing in collaboration with council, with schools, that we're just scoping out what that could look like, and with all of our staff from health, particularly therapies, wrapped around the schools to do the early intervention and meet needs and prevent the need for escalation to a consultant appointment, because we're never going to have enough consultants in the country to manage this demand at the moment. So in future, obviously spotlights will keep you updated on that, but that is a key aspect. So I anticipate that the children, young people, long waits will continue for some time to come. In elective and cancer care, just to give you, I've got a verbal update which gives you a much more up-to-date position, because there's, again, like urgent care, there's a lot of scrutiny on this. So in the elective care space, I think the main ask of us is that patients waiting over 65 weeks by December, we're at 0 or as close to 0 as possible as we can be. So the latest position on from November the 9th that I've got is that we've got 102 patients waiting over 65 weeks, but we've got assurance from our trust that they will be resolved, or largely it'll be a very small number in December that we have waiting over 65 weeks. And that is in a couple of the challenge specialties that have been well known for some time, but we've got assurance that will be resolved. For our cancer services, we are behind our operating plan trajectories, and I think the one of particular to note is the 62 days treatment standard. For September, we were 57% against 79% operating plan target, so we are some way behind. There are some very, I think, robust recovery plans that just need to be delivered and need to be realised to get us back into that position with cancer. And we're obviously in the tiering system, tier 2 across our system, so that, again, there's a lot of support, challenge and scrutiny of this with our regional colleagues as well. So those are the two aspects that I wanted to highlight from the report, but I'm sure Kath and I will take any questions.
Thank you, Mary. Any further questions? Aman, please.
Yeah, it was, thanks for the update on the children and young people. Mary, I was just going to ask a question. So it's great, all the work that you're doing, and the kind of working with the schools, but I guess I just wanted to understand, what about children that aren't traditionally schooled? They might be receiving schooling elsewhere, and do we need to worry about, do we need to consider children that might not be at school yet, and what are we doing about those children?
Yeah, this is interesting. I've learned something about this amount in the last year or so. So the children not in school, of which is a much higher proportion than I would have anticipated. Maybe that's just me, but there's more children than I would have thought, either electively homeschooled or just not able to access school because of the school systems. We are working up a model for how we can support those children as well. It's not going to be an easy one to crack, that one, I don't think, but we are looking at what we can do to support those children. It may be that we have to keep them in the traditional route of seeing the consultant, because they're obviously the most challenged children from an education point of view. So we're just working that through to support that. I think, so what was the second question again, Amanda? Just remind me the second question.
It was just those children that might not be of school age yet. So.
Yeah. The view from the clinicians is that we really shouldn't be putting too much assessment processing before children start school. Because a lot of children, I know one of mine did, as soon as they started school, they blossomed. Says a lot about my parenting, but they blossomed as soon as they got to school, and they're a different child. But they think that too much intervention too early. There's always the best start in life work that's going on, the generic work, but the actual intervention by a consultant, and unless there's an identified physical need from a therapist, they believe we should start it in that age 4 when they start school.
Okay, thank you. That's really helpful. Thank you.
Yeah, good question about home children who may be differently schooled, because I think that increased during COVID, is my sense that people kind of, that some further changes occurred, but perhaps during COVID. Let's just check. Vicky, please.
Thank you. Just a question for Kath, if I may, because Kath, as we've heard in QRD, there's been a lot of work across the system in terms of C. diff. But here, quite rightly, you flag in the report, and you flagged in QRD about the MRSA clusters. So you've helpfully outlined in this report that a thematic review of all cases has been undertaken. In terms of improved outcomes and getting a comprehensive action plan that's you've alluded to, how quickly is that work going to be taking place so that we can have confidence that we'll start to see some improvements?
Thanks, Vicky. Yeah, that work is underway at the minute, and my intention is that will be at the next quality committee for your viewing at the quality committee.
Okay, thank you very much. And Mary, I was going to ask about 65 weeks, because I think that deadline was looming, wasn't it, or is looming, where we were asked to make sure it had gone to 0, but you've given us some insight into where we are expecting to be on that. So I think if there are no further questions, it's really, we're just asked to note the performance for the system, and obviously the areas of quality highlighted, and Kath has confirmed the reporting to QRD in relation to the infection prevention and control issue that Vicky raised. So thank you very much. We note that position, and we move on to our financial plan and delivery report. Over to you, Mark.
Thank you, Chair. Good morning, colleagues. 2 parts to the paper today. Just give you an update where we're at in terms of the current financial year, and then just a little bit on medium-term planning, as Simon briefly touched on earlier. We are now in receipt of some of the allocations. If I just start with the current financial year, then the paper you've got today talks about month 6, which was September. Since we've produced the paper, we've now got early sight of the month 7 numbers, so I'll just give you some kind of key headlines in terms of where we're at there. So at month 6 then, within the paper, you could see we were ahead of plan, the phase plan at that point, by about £1 million. This has come down slightly in month 7, so it's come down by about 300,000. So we're ahead of plan now by 700,000, and that movement is predominantly within Wye Valley, which during the September-October month, we have seen an increase in use, as Mary's just touched on, around temporary escalation space, and some of the challenges there, which has again incurred some additional financial pressures in that area. Within the position now, we have now had confirmation that we've got Q3 deficit support. So as we know, we talked about previously, we get that confirmed quarterly. We've now had the 3 quarters, so that is modelled into the position. Within the numbers then, the biggest variable and challenge we've got is around the efficiency delivery programme. So you'll see within the paper at month 6, we delivered 48.6 million, and it's stepped up then at month 7. So we've now delivered 65.1. We were behind at month 6. Month 7 has now broadly come back in line in terms of the overall phase plan of where we needed to be. The movement predominantly relates though to non-recurrent mitigations that have been brought in at month 7, and that does include some balance sheet opportunities and flexibilities that have been identified have now come into the position as well. So whilst on the face of it we're delivering, again, that is because of non-recurrent mitigations brought in at that point. When you look at that then, both Wye Valley and Health and Care are slightly ahead of plan. It's Worcester Acute then that we're behind plan. They come back onto plan now at month 7, but again, when you split that down between recurrent and non-recurrent, recurrent is behind where it needs to be and non-recurrent ahead. So again, delivering, which is good. It's the mix that's a bit of a challenge. We've continued to work then on the development of plans. So we've really continued to push. It's been a conversation through Finance Committee about the delivery of efficiency and de-risking it. So between month 6 and month 7, there's more now fully developed from an efficiency perspective. We had 99 million fully developed at month 6. That's now up at 105 million. So it's creeping up, but we need it to go further and we need it to go faster. We talk a lot as well about bank and agency expenditure and really monitoring what's happening there and working through there. Agencies ahead of plan at month 7 by 5.1 million. Bank is behind plan by 4.2 million. Again, when you break that down between the individual trusts, Worcester Acute, we're seeing some of the biggest variance in that area. So again, really ahead from an agency perspective, but behind from a bank perspective. And I know from conversations linked to recovery plan, which I'll talk about in a minute, there's a number of actions being taken around usage and the rates being paid, both from a bank and an agency perspective within the trust. Across the ICS then, we are still continuing to report delivery of the plan. We reported delivery at month 6. We're forecasting the same at month 7. Efficiency is the big area of risk still. So what we are seeing now, particularly within Worcestershire Acute and within Wye Valley, is financial recovery plans, looking at mitigating actions, trying to understand what that will do to the run rates as we through the current financial year, but also as we exit the year going into 26-27, so that we're not playing that catch up continually on a month by month basis. There is risk around those. We're looking at how we de-risk them at the moment, both individually but also collectively, and we'll continue to work through that from a Finance Committee perspective. But at the moment, there is that commitment still from all partners to deliver the financial plans that were agreed at the start of the year. If I just pick up quickly then on the ICB aspect within that, so we are seeing some overperformance now against the acute part of the portfolio. Probably some of that links to what we just talked about in terms of referral to treatment, 65 weeks and waiting times. It is predominantly though within the independent sector. So we talked previously about the contracting line and the approach we've taken this year, and we are working with the independent sector at the moment around their activity management plans and how they get back to those agreed contract levels that we'd set at the start of the year, but also being clear about where is it we need to buy some more activity this year from a tactical perspective in terms of where we're seeing some waiting time challenges. So we're just working through that bit at the moment. And then the only other two areas, as I've talked about previously, is around section 117 and adult ADHD. Pleasing that the run rates have stabilised, they've not come down, but we are continuing to work through both of those areas, looking at how we manage the activity and the costs in a slightly different way, so it's more of a managed position and we know where we're going to be. So that's kind of the in-year perspective for 25-26. I just wanted to pick up then in terms of the medium-term plan. We'd included within the paper then quite an update on what we've had today, the timelines, where we needed to be. Since then, NHS now have published allocations. So the allocations came out late on Tuesday evening. So we are still working through them and trying to understand what they mean. We've only got 2 years of allocations though. So year 3 is not out at the moment. We expect that to come out at a later date, but what we've been told so far is the initial plan submission will be on 2 years. Then when we have to put the final submission in February, that will be for the full 3 years. Alongside the allocations then is the revenue, finance and contracting guidance. A bit like the rule book. What's in there? How's it all going to work? There's a lot in there that I don't fully understand yet, and I'm still working through and trying to look at the technical guidance around it to work out what it means. But just to give you some of the headlines, and they are headlines at this point. We've had 5 allocation streams, so that's the areas that we are responsible for. So things like pharmacy, the primary care contracting, running costs, core and specialised services. So all the areas we expected. It is worth just reminding colleagues we are an overfunded system. So the base growth that's initially in there at the moment is on the low side compared to what other systems that are underfunded are going to receive. So we always knew they're trying to get everybody back towards fair share. We are now seeing some of that within the base growth adjustment. They've included elective recovery fund now in base allocations. For this system, it's broadly in line with what we were spending in 25-26, so that's good. We now just need to work through what do we need to commission to hit the required RTT numbers as we go forward. The deficit support funding that both our acute trusts are in receipt of this year will step down next financial year, so it will be phased out over a number of years, and we just need to understand what that phasing looks like for both of the acute trusts. The other bit, and some of this is relevant to what Simon was talking about earlier in terms of the transition and where we're at. We've now got a funding allocation that assumes from the 1st of April our running costs will be at £19 per head. So I know Simon's talked about some of the trajectory and the transition timeline. We're just going to have to work through that as we set the plan, because potentially anything past the 1st of April in terms of reducing the cost in the areas will give us a bit of a financial pressure. We just need to work out how we manage that and phase that as part of the plan for this year. But that's a very clear number within the allocation. The cost uplift factor then, so what do we put the prices up by for our providers, all our contracts? It will go up by a net 0.03%. So 2.03% inflation increase and a 2% implied productivity. So again, pretty much flat cash perspective going into the contract uplifts for all of our providers and trusts. They've published bank and agency limits for all trusts that are looking again to see them step down over the next 3 years. And also alongside that, they published the Better Care Fund minimum contributions. And I know that was something we touched on earlier, and some of the pathways. So again, we just need to work through what's the uplift in those areas, what does it look like? There's a lot to work through in all of this. There's lots of different areas we need to understand. There's lots we need to work through in terms of what does it do to contracts, what does it do to plans? How do we look to really build in the out of hospital neighbourhood shift that we spent a lot of time talking about? We'll continue to work through that. We've got a finance committee on Friday, which we'll go into a little bit more detail, but again, there'll still be things we need to work through. But there's quite a lot, particularly over the next 4 weeks for the first submission towards the end of December that we've got to submit. So again, there'll probably be regular conversations with board and colleagues ahead of that first submission in terms of where we're at and where we need to be. So I'll stop there, Chair. I'm happy to take any comments on anything I've said or anything else in the paper.
Thank you, Mark. Rachel, please.
Thanks, Mark. That's really clear as ever. I just wanted to ask, and we'll probably touch on it more at the Finance Committee, about the sign-off of the developing medium-term plan, and given the change in our role in the ICB, what is our role now and going to be around signing off provider plans and our own plans? You know, I'm assuming that's changing, but it'd be just good to know where it's at the moment.
It is absolutely changing, Rachel, you're right. So the ICB will be responsible for an ICB plan, i.e. what we need to commission, linked to the strategic commissioner frameworks, and trusts will effectively, there's a sign-off process by their boards, a whole set of assurance and governance they have to go through. What we do need to ensure, though, from a triangulation perspective, they are aligned, they're telling the same story, they're moving in the same direction. So whilst we don't have to sign them off as an ICB, I think from a system perspective, we should probably continue to understand the correlation, the assumptions, the direction, so that we can continue on this system journey that we've been on. So again, we'll be looking to probably think about how we pull that together and work through that.
Thanks, thank you.
Yeah, and I hope colleagues would be supportive of that, because I think we don't want to get back to a world where actually, we're submitting in plans that, effectively don't stack up together across our systems, and actually just end up in disputes being escalated to NHS in England effectively, which I do recall seemed to happen quite a lot in years gone by. So I think it'd be important for us to make sure that our plans do stack up and make sense together and are coherent, because ultimately, the money is the money that we'll be working on across the whole system together. So I think that's really important. David, please.
Thanks, Christina, and thanks, Mark. It feels like month 7 is a significant improvement on month 6. It seemed like the trajectory was downhill a bit in terms of delivery, in financial delivery for month 6, but month 7 seems to be better. I was going to ask about whether we have contingency or mitigation plans in place should NHSE decide that we're not in a good enough position for them to deliver our deficit support. But clearly you said they've confirmed that they have done that for the 3rd quarter. Do we need to plan for that for the 4th quarter, or are we really confident that we'll be in a position that they will deliver that support for the 4th quarter?
Very good question, David. So whilst month 7 on the face of it appears to improve, I wouldn't want to downplay still the level of financial risk because of the step up in efficiency in the second half of the year. So whilst on the face of it we're where we need to be, there's a lot going on behind it now in terms of what's driving that and what do we now need to do between now and the end of the financial year to stay on trajectory, deliver the plan, and ensure then that we exit this financial year in the place we need to be. So there are recovery plans both from a Worcester Acute perspective and within Wye Valley Trust in terms of what needs to happen to get to that point as at the 31st of March. We are still though in conversation with NHS England as part of this new process where they're overtaking us in terms of the assurance side. And we're doing that jointly at the moment in terms of trying to demonstrate that we have grip, we have control, we're taking the actions we need to take so that deficit support for quarter 4 is released and we don't have a cash issue for the last part of the financial year.
Okay, thank you.
Thank you. Thanks, David, for the question, and Mark for the response. I mean, that latter point is really important, isn't it? Because there's increasing stories of NHS England withholding deficit support for systems which are significantly off track. So we really need to keep on, the work that we're doing, and hopefully Rachel on Friday and colleagues who will be attending the Finance Committee collectively will continue that focus of making sure that we have got a focus on the in-year position, but also obviously taking forward the work that Mark has highlighted will come through the allocations being issued and all the guidance and everything, which we'll need to clearly unpack a lot further and work through. But thank you to everyone for the efforts. So don't underestimate how difficult it is to kind of keep us focused on achieving this, but it is going to be really important for our credibility and our collective credibility that we do deliver our financial plans together. So appreciate all the work that is going into that. So thank you. Okay, Mark, I think you just wanted us to note the position. Obviously, you've given us a bit of a insight into what month 7 looked like, but also we've talked about the risks around the efficiency plans. I know there's some reference to capital position in the papers and also the medium-term planning framework and all the subsequent guidance that's been issued. So thank you for that update. We move on then to governance and assurance. We've got 3 items to cover. One is particularly important because it is for approval, so we'll focus on that to start with. I think most of these things, Hannah, we've sort of updated the board in other settings, so it's really getting us to a point where we can sign this off. But I'll hand over to you on the cluster governance update, please.
Thank you.
Thank you, Krishni. So yeah, so building on some of the things that have already been spoken about when Simon presented his report, this paper provides more detail in terms of the proposed cluster governance arrangements for the two ICBs, Herefordshire and Worcestershire ICB and Coventry and Warwickshire ICB. So today I'm just looking for the board's approval and endorsement on some specific issues as Krishni has set out. So firstly, the proposal is to align and streamline the membership of the two boards as much as possible, resulting in 4 executive and 5 non-executive shared voting board member roles. This is over and above the chair and the chief executive, who are already appointed and in place. Partner member roles are bespoke to each ICB geography and cannot be shared, but the proposal is to reduce these from 7 to 4 on each ICB. So I'm not going to go through the detail which is set out within the paper itself. And just to say, the paper not only sets out the voting membership, but also the arrangements for participation at the board in common, which will come into place in January next year. So then related to this, but stretching beyond just the board membership, is the constitution of the ICB. And as part of the clustering process, both ICBs are required to review their constitutions and, where practical and sensible, align these as much as possible. So the key changes are to the constitution of Herefordshire and Worcestershire ICB are set out on page 4 of this report. Following the board's endorsement today, the constitution will be submitted to NHS England for approval, because it is within the gift of NHS England to approve ICB constitutions rather than the ICB itself. So then the third and final element of this report is the new proposed joint committee structure, which is attached and described in more detail as Appendix 2. And it's important to know this is not the full committee structure, it's the first phase really, which focuses on the core 6 corporate committees. So that's Audit Committee, Remuneration Committee, Corporate Management Committee, Strategic Commissioning Committee, Strategic Finance Committee, and the Integrated Quality, Performance and Assurance Committee. So the first 3 that I have mentioned, those terms of reference are brought today for the board's approval, and the latter 3 will be finalised and brought to the meeting in January. So finally, just the appendix 2, just to point out, not only sets out the committee structure, also looks at the high-level remit for each committee and the transition arrangements and timescales for transition. So to summarise, I'd like to ask the board's approval to endorse the constitution changes which have been proposed ahead of formal submission to NHS England, endorse the new composition of Herefordshire and Worcestershire board, and approve the high-level committee structure and the 3 sets of terms of reference which are presented to the board today. I'll pause here, Krishni.
Thank you, Hannah. So before I ask whether colleagues are happy to do that, are there any questions? I mean, hopefully we've kind of talked through this with people and explained the context for some of the changes, bearing in mind that we now are increasing our membership across the 2 systems, which is part of why we obviously need to make some of the changes we are. But is everyone content with the rationale and therefore the changes that have been proposed? Yeah, I'm not getting a sense there's anything that people want to clarify. So on that basis then, we will endorse the changes made to the constitution. So everyone happy with that? Obviously the composition of the new board as part of that, and the approvals, which are the committee operating model, which Hannah has highlighted, and the terms of reference for the 3 committees that we're establishing at this stage, with others to follow. If everyone's happy, we shall confirm our support then. Great. Thank you very much, everybody. So we have 2 final items, which are more general items that we have at the board, which I'll come back firstly to Hannah to introduce the committee escalation report. Hannah.
Yes, thank you, Krishni. So really busy period in terms of committees, but there is nothing particular to highlight from me. So it is really only whether the chairs of each committee would like to, highlight anything from their point of view.
Great, thank you. Rachel?
Yeah, thank you. It's just just building on some of the conversations that we've had before around the finance committee, you know, part of our continuing work is not just in year, but it's working on this medium term planning work, which I think is really important. And I want to make sure that we're all still engaged in that, because that's what makes us a successful finance committee, really. Engagement from all organisations, sharing assumptions, making sure our assumptions are consistent and dovetail with each other, and everybody's still like really engaged in pushing that agenda forward as a committee, because it's kind of, we split our committee between in-year delivery and future planning. And I think, given the changes that we're undergoing at the moment, I think, as we've said before, I think that's a really key part of the committee for us. So I just wanted to highlight that and hopefully make sure that everybody's still committed to moving that work forward as we've been doing.
Thank you, Rachel. I think there was sort of, I don't know if partners want to comment on that, but I think there was sort of certainly comments of support in the chat around that. So hopefully that will continue to be welcome, because I do think, as I said earlier, it's really important that we work together to make sure our plans are coherent across the board, and there's a good sense of collaborative working through the finance committee, which feels important to sustain. So I welcome any comments on that from colleagues, but in the meantime, Vicky.
I think just to say that we've had some really good coverage in today's board discussion that is covered in QRD, so nothing else to raise, but again, ongoing good support from providers in terms of attendance of non-exec chairs of quality committees, so appreciating that support.
Great, thank you. And I certainly wanted to pick out some things that have been supported through the Strategic Commissioning Committee, which I always think are helpful things to highlight, really, like the Dementia Post-Diagnostic Support Service, which sounded really a positive development, and indeed the Hospital at Home extension, which I think are really sort of positive developments, really. So I don't know if Stephen or Beej would like to comment, or Russell, on Rachel's point. Beej?
Yeah, I think it's fair to say it's been a pretty bumpy journey in respect of thinking about our medium-term plan, but that's absolutely understood because it's a really complex exercise. I would say that Mark and the team, Rachel and the committee have done some amazing work so far. There's clearly lots to do, but it's a vital ingredient in continuing to make sure we're talking about our collaborative view on where we are financially right now, but also more importantly into the medium term. So very, very supportive of continuing that conversation.
Thank you, Beej. Thanks very much. That's really helpful. Russell, did you want to make a comment?
No, similarly for me, I think the opportunities we've got are obviously the transformation agenda, which, going back to Simon's introduction, we were talking about earlier. We've got to find ways of delivering our services at a lower cost to the taxpayer, which allows us to free up funds across the different parts of our system. And the second, particularly in the acutes, is to ensure that we do everything we can to minimise acute episodes. Acutes should be there just for the acute episode. They shouldn't be there, given how expensive they are, for anything but acute work. And the third point I'd make is I really do think we've got to be ambitious on our productivity from the acutes. There are opportunities in terms of fragile services, which we've touched on with Marie's work earlier. But generally, we really do need to aspire to be amongst the very best in terms of productivity. And my final point is one I popped into the chat box. It sticks in my stomach how much money the independent sector make out of the NHS, and I think as part of our medium-term thinking, how we can, and I know we've made good progress this year with the 10 million reduction in IS spend, but we really do, I think, need to have a long-term ambition to reduce to the absolute bare minimum the independent sector work that occurs, not just in physical work, but also in terms of mental health work, and get that money back into the NHS and our council colleagues so we can use it more efficiently.
Thank you, Russell. Simon, did you want to comment on that at all? So I guess there's always an issue about patient choice as well, isn't there, that we have to balance off.
It's really important that we respect patients' right to choose. A lot of the independent sector activity is driven by choice. I'm hopeful that we've set quite a good tone this year in that we've had really clear activity plans with all the independent sector providers. This is what we need you to do for us this year. This is what will enable us to hit our RTT commitment. It does put quite a reliance on the local trusts, who we asked to probably do more than they would have done. So it is critical both sides of that equation are balanced. I mean, I think we have to be careful not to be totally kind of favourable of all the local trusts. That's important, but the local trusts have got to kind of get their offer up, the quality of their offers, so that more patients are happy to choose their pathways as well. That's the other part to this, that we've got to get higher quality in some of these specialties, and if that happens, actually it will be minimised because patients will be making that choice anyway. There are a whole load of contracting things we can do in the background, but fundamentally we've got to get the quality right, haven't we? So it's a fine balance. Russell, we've worked quite closely together this year as a board. Actually, you remember we had a couple of conversations right at the start of the year around the contracting approach we agreed to take. I now working in another ICB that didn't do that. Actually, you're right, the independent sector activity is growing exponentially, so that is one of the things we'll look to do across the cluster in planning for next year, is to be just really crystal clear with all providers, both trusts and independent sector. This is what we're commissioning you to do. This is what we need from you next year in order to deliver the waiting times that we need for our patients. But we're going to be coming back to this, I've no doubt, both in the planning process and in future as well.
Thank you very much, Simon. So I think, some important points there about the importance of productivity and quality of our NHS services as well, which actually I think are beneficial for everybody. So there are no specific items, I think, that we wanted to highlight from those. It's really there for assurance predominantly that the committees are functioning effectively on behalf of the board, and for your noting. So thank you very much. We have our final report, which is the Board Assurance Framework Report. So back to you on that, Hannah.
Thank you, Krishni. So you'll be able to see from page 2 where we summarise all our priorities and the progress within those priorities in a dashboard, that we now have 4 priorities who are hitting the target assurance level, which is really positive at this point in the year, and 2 priorities where we have increased the assurance level, but we are not yet tracking at the target level that we have set. So because we are kind of halfway through the year now, we've done a little bit more of an in-depth analysis, and you'll be able to see that on pages 3 to 10. So that looks at the layer below priorities. We call that success measures. And that really pleasingly actually shows a number of improvements and sort of elevation of assurance level for those success measures, which means in turn that should soon result in an improved assurance level for the overall priority. I did want to mention, though, however, that we do have 2 success measures where, although there hasn't been any decrease in assurance, we are currently tracking 2 levels below where we should be. So the first one is ADHD, which is obviously well documented and well discussed and has been discussed at board even today. The second one relates to primary care patient strategy. For that one, it's more of an issue of timing. Kath can always add more on that if she would like, but essentially we are quite confident that we will reach the target assurance level or get as close as possible later on in the year. So it's just a matter of timing. So then finally on pages 14 to 17 is a summary of committee endorsed risk changes, largely relating to risk downgrades and closures. You will notice a slight discrepancy in terms of the industrial action risk. And that is purely timing. Again, it is because we go through a process of committee approval, so it feels a little bit out of place, but it's kind of reacting to a situation that was a few weeks ago. So that risk is live and is being reviewed again, and that risk score will go up again before it goes down. So that's it. I'll stop here. There's a lot of information in the report, but I'm happy to take any questions.
Thank you, Hannah. David?
Thanks, Christian. Thanks, Hannah. I think it's a point which I may have mentioned once before. So on 5B, I understand the limited rating, but it's good. I think it's good for us to note that the broadly agreed actions have all been implemented to do with staff satisfaction and morale. So all those have actually been implemented, but of course there are other factors which we didn't anticipate, which will mean that it's probably correct that it would be a limited assurance there.
Yeah, thank you, David, because of all of the uncertainty and of course changes that have since been announced. Vicky?
Thank you. I think it's just a comment, Hannah, on the de-escalation of dentistry, because it's such, we've celebrated the success around dentistry and the improvements that have been made, but it's such a comprehensive list of rationale to support the de-escalation. There can be no debate about it, but it was just a comment how comprehensive that was.
Yeah, there's been a lot of really positive work in that area, and we should recognise that, I think, given the very challenging position we were in when we first took on the responsibility for that. So thanks do go to the colleagues who've been involved in that. I was going to raise the question about the planned industrial action, Hannah, so you've answered that question, so I think that's helpful to note. So if colleagues are happy and there are no further questions, it's there again for our assurance that we are reviewing our risks and noting changes, and it is a constant process that is reported to the board, and I think much of those key risks have been discussed through the course of this meeting, which you would expect to see, I think. So thank you very much, everybody. So I think that brings us to the conclusion, not far off the original planned time, of our main core public meeting. Our next public meeting is Wednesday, 21st of January, when we will be meeting as a clustered board. Before I close, I just wanted to remind members that there is a confidential session. I think it's currently scheduled to start at 12 o'clock. Is that right, Hannah? So at 12 o'clock, confidential session, which we do need members only, please, for, and relevant execs who are supporting that. Clearly, some colleagues will have some conflicts of interest. I think we've already agreed that those colleagues will not be present. So I just want to make sure colleagues are coming back for that meeting at 12 o'clock, and there's a separate link to that. But in the meantime, thank everybody for their contribution today. I also wanted to, because I think we've had a really good discussion, and I think it's been we've covered some very important ground, particularly in advance of winter, and I hope members of the public who have observed us today would have found that meeting interesting and useful. I also want to take the opportunity just to thank Sarah again, as this will be her last meeting, and again recognise her contribution. I know we'll be continuing to work with Sarah in her various guises in Coventry and Warwickshire, but just want to take that opportunity again to thank her. So unless there's anything else, Hannah, that I needed to mention, I'm going to close the meeting, and we'll reconvene at 12 o'clock for the confidential session. Thanks, everybody. Thanks for your contributions.